All right, so let's get back to this is part two for pathology, IEA questions for DERS. Okay, where we here? 25-year-old Asian woman, uh, high blood pressure. Again, this is a vignette that's describing a hydration mole. So we got level high blood pressure, positive pregnancy test, which basically means beta ACG is high. No fetal tissue, and storm appearance. That means it's a complete, uh, and that means probably has like 46 chromosomes. Uh, Edematous villi is also an indicator. Uh, what is associated with this? Uh, Hypotension, 0% risk of choriocarcinoma. I said this one is wrong. Why? Because uh, the complete one does have a chance of going turning into choriocarcinoma. The partial one, I think, it has a super rare chance of it's still not zero. MSS, I don't know about elevated T3 T4. This is it's an interesting one. Um, I think that's the answer. Yeah. So this guy, remember I said, produces a crazy amount of beta HCG, right? And that causes a bunch of things. First of all, it can cause some cysts in the ovaries because of the high hormone level. I want to make myself smaller here. Right, because of the high beta HCG levels, it can cause some cysts to form in the ovary, but they're not called follicular ovarian cysts. Uh, Follicular ovarian cysts are the more common cysts that like they form each month and they pop a ovum out. So this is not it. But the other thing this can do is that has similar structure to TSH, right? And it can cause increased levels of T3 and T4. So C is our answer. Forgot to start my timer again. I'm a little maybe like 2 minutes has been passed. Okay. 62-year-old this time. Conservation weight loss, feels full, lost 12 pounds. Um, Bilateral masses in at nexal, which is where the ovary is. They're kind of like cystic, heterogeneous cystic spaces. A primary ovarian malignancy suspected. So that rules out this diffuse stomach type of carcinoma. Shows the following most likely be elevated on these patients. So ovarian cancers, one of the main. Let's actually walk through what each one is. Alpha fetoprotein, you can see it in a lot of germ cells. Um, you can see it in maybe dysgerminomas. You can see it in uh, the yolk sac tumor, the embryonal tumor, a lot of those guys. This CA19, you can see it in pancreatic tumor, beta ACG, again, a lot of the germline tumors, LDH, you can see it in dysgerminomas plus seminomas, which are kind of the same thing in different genders. Seminomas for guys, dysgerminomas for girls, and CA 12.5 is basically what you see in ovarian cancers. Okay, this is a not a bad question. It's kind of micro, but it's okay. So, 20-year-old cauliflower-like lesion on the vulva, vagina stuff. What is the patient got? So, uh, it's kind of like so you we like cauliflower-like. You get hyperplasia, right? Your like stuff is producing more than it's supposed to, and it's like one of the HPVs. Now, what you gotta know is that HPV 16, 18, and I don't know, like 30 and 31, something like that. There's two in the 30s. Uh, these four are high risk, uh, and they what they give is that they give um, like neoplasia, right? So they give like the CINs, your cervical interepithelial neoplasias. So these guys cause like actual like squamous cell carcinomas, right? But they're not raised or anything. They're just like they're flat, if this is like your basement membrane, these are your the cells. The cells just look abnormal here, and at some point they're gonna get malignant and they're gonna invade and they're gonna result in a carcinoma. But the ones that kind of like produce warts or like cauliflower lesions or condylomas, they're the low risk ones, and they're 6 and 11. So 6 and 11 is uh, for this one. So 6 and 11, these guys don't cause uh, they don't cause cancer. They don't cause interepithelial neoplasias, which is basically abnormal cells within the epithelium. They call the lesions like this, like cauliflower lesions. They're called condylomas. All right, 30-year-old woman. She's 10 weeks pregnant. Elevated beta ACG. There's grape-like vesicles. So another hydration mode question. So one thing I forgot to mention is this, that if so in developed countries, usually like they, because they do prenatal testing, they do a ultrasonography and they see, oh, cis there's snowstorm appearance, or oh, there is like partial fetal parts here. But if less developed countries, they don't do that, and how you end up like realizing you have a hydration mole is that the girl sees like, oh, like grape like vesicles coming out of her vagina. And so maybe, so this is an important point too. um, but basically we got to distinguish which type that is. Let's read a little bit more. But there's an image without, without any fetal parts, right? So if there's no fetal parts, it means, so there's, in hydration moles we have partial fetal parts and no fetal parts. No fetal parts is complete. Partial fetal parts is partial mole. So complete, and if you're looking at complete, and I said like in this case it's always the dad's fault. So the chromosomes come from the dad. 46XX is your answer then. So here we got 30-year-old. She's a recent miscarriage, so it's already making me think of maybe the miscarriage, like some of it remained and invaded and caused like maybe a mole a choriocarcinoma. But I may be reading too much into the question by now. But I just wanna like let you know of how I think of the question. When I see a question, like all the differentials comes into my mind. She recently had her first child 2 years ago. Um, she's had, oh, it's totally not a choriocarcinoma question. She's had heavily menstrual bleeding, so physical examination shows pelvic mass ultrasound, asymmetric enlargement. So basically, what's describing is that there's like these masses within her uterus. So my fantastic uterus drawing skills. These are the ovaries. There's like these random masses within the uterus, and she had a miscarriage. She's bleeding heavily. Biopsy shows well-defined spindle-shaped cells. Right. So all of these are important. So these guys, this is a leiomyoma, right, or a fibroid. It's really common. Um, so they're smooth muscles, right? Remember, smooth muscles look like this. So well-defined spindle-shaped cells, that's what they're referring to. It's a smooth muscle tumor. Symmetrically enlarged because she probably got a big one on one side, So what they do is that they cause literally heavy bleeding and miscarriages. They reduce your fertility like that. So and they're benign. There is also leiomyosarcoma, but these guys don't lead into that. They're like they come from the same cell of origin, but leiomyomas, who are super common, don't lead into leiomyosarcomas. They're not a precursor lesion. Um, so high mitotic activity is not, sounds like it's trying to clue us into, oh, super malignant, super fast growing. It's really not what these guys are. Invade myometrium, really not what these guys are. Necrosis hemorrhage when not pregnant, no. Oh, one other thing about these guys is that they're super estrogen sensitive. uh, so when you go over, estrogen replacement therapy, or when you have like, I don't know, like maybe a tumor here that produces, and the ovary that produces estrogen, just like the endometrial lining, these guys like respond really well with estrogen, which means when you go through menopause, when that causes estrogen to drop, and that will cause shrinkage of these tumors. So these tumors will shrink after menopause. All right, so here we have a 55-year-old lady, uh, abdominal distension, kind of early satiety, weight loss, papillary masses on adrenals, on adnexal, so kind of like has GI symptoms and adnexal tumors. It's making me think of that the diffuse carcinoma of the stomach that can metastasize easily to the ovaries. Positive, so she's got ascites again and pleural effusion, right? Uh, and then thoracocentesis is tested for negative any malignancies. A biopsies of the mass is performed. Which of the following is so? It's not what I thought it was, right? Because uh, we have ascites, right? We have pleural effusion. Pleural effusion, you shouldn't expect that with the thing with the diffuse carcinoma, right? So this is basically when you have fibromas of the of the ovary, right? Fibroma of ovary, you get a couple of things with it. You get peritonitis, or no, not peritonitis. You get ascites, and you get pleural effusion because of this fibroid. It's like a fibroblast tumor of the ovary, and you can. There's also this like saying that it's there's a they feel a pulling sensation, like a pulling sensation on like their genitals, the woman who have this. And so as I said, it's like a fibroblast kind of tumor. So fibroblast, smooth muscle kind of tumor, not smooth muscle, but fibroblast. So you were expecting like that, like kind of like like spindle shape. Oh, and it's fibroblast, right? So spindle shape, um, fibroblast tumor. So if it was the diffuse type, right, would probably mention single cells. Would probably mention, there's also a GI problem. Should stop like saying my guesses before I read the question because I think it could be distracting to some people. 38-year-old, considerable pelvic pain during menstruation. Okay, I have certain things I'm thinking of. Heavy painful menses, two miscarriages. Uh, there's cysts along the fallopian tubes and in the right ovary. Biopsy after cyst shows red brown colored collections and glands, right? So when I was reading here, like considerable pain with each menstrual cycle, the thing that came to my mind was endometriosis, right? So what is endometriosis is basically endometrial tissue elsewhere, the places it's not supposed to be. The most common place is a fallopian tube, there's a fallopian tube here, and the ovary, right? So the theory is that every time like you men's, like you lose this lining, some of it might retrogradely go back up and land somewhere else and like start living somewhere else. And so these people, every time they have their period, they're like basically having inflammation and pain because they're not only losing like tissue from here, they're like losing tissue from here, or maybe it goes in the, this is like, let's say the stomach, maybe it like goes right next to the intestine, and it also causes intestinal problems. But the most common cause, as I said, is these guys, the ovary and the fallopian tubes. And it's characterized by this. It's characterized by red brown colored collections of the kind of like cysts. And the reason for that is because, let's say we have a little bit of cells that come here, and each month they bleed into themselves, and like they heal and they bleed and they heal and they bleed and they heal. And the it's not bleeding, but like, the tissue, and there's some bleeding too. It leads to the brown and like the red color. So endometriosis is what I thought of when I first read the first description, but also it kind of cleared it out that, oh, there's these cysts on the fallopian tubes, and oh, there's like they're brown. Also, there's low beta HCG. That's really important because then like there's something in your fallopian tubes, but it's not an ectopic pregnancy because it would have had high beta HCG. See. All right, so this is number 20, question number 20. Shit, we've been really slow. So 57-year-old, last 5 weeks, physical examination mass, right? So 57, 52-year-old, there's masses in the ovaries and some weight loss, pelvic resistance, okay, more just description of ovaries. And so it's saying uh, the description of the cells is mucin filled cells with nuclei pushed to the periphery. So I've said this 1,000 times so far. These are singlet cells and they're from the stomach. And they lack ecaterins. Important point. Yeah. So 55-year-old, some weight loss, uh, thick endometrium. Okay, maybe so. I'm thinking of high estrogen for whatever reason, but this is not that case. This is just saying so. Uh, yeah, it is. So this fifth to late postmenopausal has thick endometrium. Endometrium is kind of like invading the myometrium, so it's kind of like a this is kind of a endometrial carcinoma at this point. But it's asking me that mass that was in the ovary, right? That was so. What is biopsied? Oh, the endometrial gland is biopsied, right? So she has, for whatever reason, high estradiol, and then that caused her endometrium to get thicker, and it's finally invaded. It's asking. So the biopsy is from. So I guess the mass is somewhere on the. Okay. So it's kind of a weird question. They don't. I don't necessarily like all these questions. They just have like a lot of points that I haven't thought of before. That's why I do them. So this basically you got a thick endometrium because of some estrogen. You got to think, oh, what does produce estrogen, right? If it's a tumor, it's tumor within the ovary. It's probably what? It's probably a granulosa tumor. And remember, call your granny an X. Call your granny X. So these tumors have the call bodies. But I mean, it doesn't even say which one was biopsy. So I was thinking of like biopsying the endometrial lesion. I was like, okay, what would I expect to see? So 16-year-old has hirsutism, uh, mm, doesn't hasn't have had a menstrual period for 7 months, enlargement of the clitoris. All right, so we kind of get the vibes of just like this girl has a lot of androgens in her for whatever reason, and then uh, so we kind of assuming like a hormone secreting tumor, and kind of like a the only thing that's a Leydig cell Leydig what is it called, right? Yeah, Leydig cell tumor is the only thing that comes to my mind, and those guys have these ranky crystals. It's not common in women, but and in men the way it presents is that in boys it presents with early puberty, right? Again, you see the Leydig cells produce testosterone, and they have the renic the rank crystalloids, right? But in older guys, they produce the testosterone, and then testosterone gets reduced or it gets turned to estrogen, and so those guys will get gynecomastia. So early puberty in young boys and gynecomastia uh, in older adults. Infectious question. So basically this question is describing diabetes mellitus type 1 and it's asking you what it is. So let's say you forgot. You're on the exam, you forgot how it was. The way you're gonna think about it is, or the way I would think about it is, okay, these islets, something is destroying them, and I just like know the picture of like lymphocyte infiltrating the islets. So I was just gonna go with. So I mean, these three don't make any sense, right? Uh, and it's a 5 year old, so this one doesn't make sense either. So it's like the question is it like through antibodies or is it through cells? Then I just had this one. I just remember it's cells that invade the the islets. So that makes it a type 4 type hypersensitivity. Right. It's one of the questions I got wrong. 75-year-old has had a long standing history of diabetes mellitus. Truck driver doesn't take his medication. Uh, he's urinating frequently, has high blood pressure. Um, what do we see on histology of the kidneys? So it's kind of a kidney question. I didn't know this question at first. I thought the answer was D because lamination of lamina densa, but because we have like all glycosylation of stuff. But the answer is B, diffuse nodular glomerulosclerosis. And just remember those like this is your glomeruli. Remember those nodules, like those lesions that are produced like in diabetes, like within the glomeruli. You also have haline arteriosclerosis in diabetes because of the high blood sugar. So, question 30, we got a 30-year-old. This is tremor and periorbital edema, right? Or like mixed edema and exophthalmos, right? It's just sort of a hyperthyroid of some sort. And uh, it's asking what else, or like what does this lead to? So just gonna know exophthalmos leads to corneal aberrations because the eye gets pushed out so much that the lid doesn't close, and that causes the cornea not to be protected well, and you get aberrations. I didn't know that before. That's why got this wrong. So it's a question mark, which means I don't like this question. 45-year-old, 15 kilograms weight loss, lump in her throat. She's from South America. There is a mass in the right thyroid, uh, well differentiated, malignant thyroid follicles that have invaded the capsule. So it's a follicular carcinoma, right? So follicles, there is also capsule that have been invaded. So it's a carcinoma, not an adenoma. Um, so I think that this is keyed as iron deficiency, but I don't think, yeah. But yeah, I did some research, and for follicular thyroid carcinoma, what they say are that this is from Up to Date, which is like super trusted in the field of medicine, and we'll be familiar with it once we start our rotations and our residency. So it says follicular is similar to papillary and includes radiation exposure during childhood, history of thyroid cancer, first degree relative and family history of someone with thyroid cancer. Um, and it says the radiation exposure is the most clear factor. It doesn't say so ionization. Hmm, yeah, I guess radiation would be non-ionizing radiation, or but I don't like this question for that reason. I don't know what they want from us when simple Google search like shows you something that goes against what's being thought. I don't even know if that's being thought in our lectures. So 45-year-old has been gaining a lot of weight in the midsection. As so gaining a lot of weight in the midsection makes me high cortisol. Then I read stretch marks. I just think of more cortisol, and then basically he got like hit somewhere and got a bruise, and it took like weeks for it to heal. So cortisol, one of the things it does is that it basically fibroblasts that are repairing cells, it slows them down, right? That's why you get stretch marks. That's why you get delayed healing, and yeah. So glucose is high. That's the other thing that cortisol does. It's a glucocorticoid, which means it is transforming all forms of energy from fat to carbohydrates. A lot of it is to glucose, but some of it is also glycogen in the liver. So it's just pushing everything more towards uh, the carbohydrates, because carbohydrates are more accessible sources of energy. You can burn carbohydrates faster, and remember, cortisol is like a stress type of hormone, so it's getting you ready for a situation where you might need fast access to a lot of energy. But you have low ACTH, high dose dexamethasone suppression test shows no improvement. So you have low ACTH, which means uh, and no suppression, right? And then it's asking what are you gonna see. So we have low ACTH, which means the adrenal glands themselves are producing it, maybe one or both of them, right? They don't respond to dexamethasone, which is expected, because dexamethasone, the only thing that does respond to dexamethasone is a malignancy, or not a malignancy, but is a neoplasia of the pituitary, right? That's the cells that produce ACTH. Um, so it's basically asking what does the adrenals look like. So I'm thinking it's C, because probably something happened in one of these cells. You got like a metaplasia of like a hypertrophy of some sort because of like a mutation or something. So this guy got bigger, and then the pituitary realized that and decreased ACTH, right? Because of negative feedback. And then so when there's less ACTH, this guy doesn't get as much growth stimulation, so it grows smaller. This is keyed wrong. Let's see. Let me just make sure. Yeah, it's keyed wrong. It was C. This question I gotta look more into it. I'm not sure what exactly this is. The fluocortisone suppression test, the FST. My understanding is I didn't also like I understood it, but I didn't like the choices. I thought it could be a better choice, but basically this guy, the fluorocortisone, corti whatever, right? This guy acts similar to aldosterone. So when you give it to someone, the way they should react normally is that their renin goes down. So, you know, and then uh, they respond with lowering their renin. Again, I don't understand this super well, so I'm not going to spend a lot of time on it. I'm going to talk about the things I understand well. All right. So we got a 19-year-old. It's got stiff. Oh, I know what this is. So this 19-year-old girl was found, unconscious, sniffed neck. Um, so kind of you're thinking of like sensitivity to light, kind of like a meningitis, and then it's starting to show you signs of like okay, actual meningitis, right? Like glucose was low in the CSF, WBC is high, you know, there's high protein in CSF. Okay, we get it. She's meningitis, and then we were wondering why did she fall? So basically, when you have sepsis with some sorts of bacteria, what they can do is that they can cause, and like meningitis with those bacteria, they can cause hemorrhage into your adrenal glands, and it's mostly capsulated bacteria, but they can cause so hemorrhage in your adrenal glands, and your adrenals die basically. So you lose cortisol. When you lose your adrenals, the thing that's going to get you is that you lose cortisol, and then you're going to downregulate your beta and alpha receptors on your vascular cells, right? The cells that the smooth muscle cells of the vasculature, and then you're going to lose tone in your vasculature. So you're going to drop your blood pressure, and that's going to cause you to kind of crash. So uh, I didn't all I mentioned. The bilateral hemorrhage leads to low cortisol. Low cortisol leads to low vasculature tone. That leads to the person kind of like passing out. I don't know where. All right, I'm gonna finish this.